Good afternoon. I'm Sheria Robinson Lane, and I am faculty at the University of Michigan in the School of Nursing. And let me see here. The topic I'll be addressing is role adjustment and caregiving self-efficacy. And as I was thinking about this and the work that I've been doing, I do have to admit that interestingly, like my work is not looking directly at role adjustment or at role strain. But I've been thinking a lot about this concept of the familial roles and how this influences care outcomes, and particularly caregiving self-efficacy. And that's because, in the context of my um, work, I tend to look at a stress process model of family caregiving, and particularly dementia family caregiving, where we know that caregiving is stressful. And so, in work with Black family caregivers of persons with dementia, when we've met with focus groups of caregivers, some of the challenges that they've experienced that we know have contributed to this overall what would be deemed a stressful experience are things like unexpected financial challenges, like as has been mentioned in some of the previous presentations or the last of, if you want to take care of individuals, particularly if you're living together, it often requires a change in your employment, particularly for these Black caregivers, that changes income. The cost of services like respite care is often expensive and not covered by typical insurances for individuals who sit above the poverty line. And as one caregiver mentioned, it's like if you want to take a vacation, you got to pay two times. You got to pay for your vacation, and you also have to be able to cover the cost of services if you want to take a vacation without your loved one. There's also unrealistic family expectations, as we know from the presentations over the last couple of days, that often family caregiving does not take place with a single individual. There's often other family members that may or may not be engaged in other aspects of care, but certainly individuals that are engaged in opinions regarding that care, whether they're directly engaged or not. And oftentimes, these expectations around what that care looks like can be unrealistic, where the person that may be providing some of the more hands-on aspects of care may not feel as though they're getting the support from other family members. Even though they might be a part of a supportive network, that a lot of that responsibility or burden still may fall and not getting the support that they would like. There's also a lot of incidents of loneliness and isolation, simply because of the particularly with high intensity caregiving, where individuals are engaged in more of those activities of daily living, particularly as the disease progresses, where you're seeing more hands-on care with things like bathing and toileting, and sometimes in the earlier stages where it can be, in some of our previous work, we've shown that it's more stressful actually than in the later stages, because the individual is still exhibiting a lot of challenging, or can be exhibiting many challenging behaviors. They're still mobile and may be putting up some resistance to support because of this need for independence that most older adults really hold dear. Families also report gaps in medical support, meaning they often aren't brought into care until it's in the midst of a crisis. And so they often may be aware of what's happening, but there's really poor communication with providers around it. And this is where we see challenges like literacy show up, where how information is relayed may not be relayed in a way that caregivers fully understand it. And so, like, for example, one caregiver expressed not knowing that her mother had dementia because of the way that it was described to her by a previous physician, where they didn't use the exact words dementia. And I don't remember at this current time the exact phrase that was used, but it's a phrase that medical personnel may be more familiar with, but a lay person that's not in the healthcare field may not be as familiar with. And then, of course, we know that there's a lot of research that indicates that there's a relationship between stress and neuropsychiatric behaviors amongst individuals that are receiving care. And so also within our work, we found that the difficulty in managing some of these behaviors also contributed to caregiver stress. So in particular, when we talk about neuropsychiatric behaviors, what we're talking about are things like delusions and hallucinations, where it's common for care recipients to, for example, accuse their relatives of stealing money. And if you're part of a large family network, they get on the phone and tell another relative that the money is being misappropriated. The family doesn't understand that this is a common delusion. And so now you're dealing with the relative that one is taking care of, in addition to other family members, and trying to defend choices around finances, which are oftentimes, sometimes inflated around what money is actually available versus what is really there. A lot of families struggle with agitation and aggression, and seeing their loved ones become more aggressive who didn't have a history of aggression, or ones who did becoming more aggressive. And you can understand how incredibly challenging this can be for individuals who may have experienced child abuse that are now taking care of a parent, or other individuals who've had a history of trauma that are now in a situation where they're in a caregiving relationship. We see increased depression and anxiety amongst the care recipients, which often in other studies we've shown that it's had a dyadic interaction. So when there's depression in the care recipient, that sometimes this we'll also see increased depressive symptoms in the caregiver. We've also seen issues around sleep and nighttime disorders when there's sleep disruptions, that this also influences the caregiver health. The disinhibition and irritability can also lead to, as well as that aggression, can increase social isolation because it can be limiting around how the caregiver is able to take the recipient out in public settings. For example, if you have somebody that's not willing to keep their clothes on, they do have special clothes that can make it more challenging, and there are some medication interventions. But sometimes it's more simple to just simply stay home, to not have to do all of this extra work, as some caregivers might describe it, to manage these behaviors. And then, of course, the motor behaviors is relating to the pacing and shuffling things around, a reorganization of the home, and the appetite or eating disorders can just be challenging more towards the later stages of care. In the earlier stages of dementia, this may be because the person may be hard to get them to sit still to eat a meal, having to change what is served or how the food is served in order to get the person to eat regularly. So all of these are ways in which it can be stressful to the caregiver, but also ways in which, like, there's this sort of role adjustment that takes place, where the individual has to go from their previous relationship with the individual, whether that might be as a spouse or as a daughter or as a friend or as a neighbor, to this different, sort of less defined role that both individuals may struggle against. So what does that look like when a parent isn't able to parent anymore? And now a child now has to move into a parental sort of a role, but there's not necessarily a book or a manual or anything to prepare you for that, or how to fill in the gaps of how to deal with these relationship changes. We also know that all of this is influenced by or affected by social determinants of health, which many could also refer to as political determinants of health, because, of course, politics affects things like economic stability, education, what education looks like in various communities, who has access to education and at what levels, access to healthcare and healthcare quality, as well as social contexts like the support systems that individuals have available based upon the communities that they live in. So who lives close to them or non-close, and then coping strategies are often familial, right? We learn from our parents on how to cope with the difficult things that happen in life. And then these extend to our workplace settings and our community settings where we engage and learn about coping strategies across the life course. So all of these determinants can play a role in health outcomes and can ultimately influence the care that individuals receive, how they access care, how they're diagnosed with dementia, how they receive access to supportive services, as well as it can play a big role in health disparities, and so differences in who has access to what sorts of services or information at what points in time. And so, specifically in my work, when I look at Black family caregivers, what we know is that they, of course, have an increased risk for Alzheimer's disease and other cognitive impairments. Dementia-related diagnoses are often at the later stages, which can be challenging in managing symptoms ahead of time. And that's where we get to, as was mentioned, this idea that it's more common to come into caregiving in the midst of an emergency. Or as we often say, people are voluntold into caregiving. You don't necessarily volunteer, you just have to. I have a question mark around lower education because a lot of literature talks about educational differences when looking across racial groups. But I think that what I've been seeing is that this tends to be more the case for older adults who may have comparatively lower levels of education, but amongst family caregivers who tend to be younger, more often to be daughters rather than spouses or care partners, education is actually tends to be a little bit higher. Um, where individuals tend to have at least some college, but we still do continue to see relatively lower comparative income when compared across racial and ethnic groups. We also see increased comorbidities and overall disease burden amongst these caregivers with high incidence of cardiovascular related health conditions such as hypertension and diabetes. And so one of the stress and coping models that I frequently use in my work is the Roy adaptation model, which is it's a disciplinary model, a nursing disciplinary model that really operationalizes stress and coping processes by specifying key adaptive and modifiable domains. And so the Perlin model that most of us are, of course, familiar with in the family caregiving work, which conceptualizes caregiving as a chronic stress exposure, where the care recipient behaviors and care demands are primary stressors that influence psychosocial functioning. What this model does is it seats it within a space where we're able to think about particular health interventions related to how individuals are adaptively coping, and we think about the individual as a holistic individual where they have components of self that are physical, others that affect the self concept component, others that affect role, and others that affect interdependence. And so when we examine or do assessments based in these areas, we're able to think about making sure that we're addressing the whole person in the interventions that we develop. So within the physiologic domain, what that might look like for a caregiver and poorly managed hypertension or increased risk for poor cardiovascular health, or more globally, poorer rated, self-rated health if we're using like a promise global health scale. Within the self-concept role, this is around, has to do with the beliefs that an individual has about themselves and their sense of self-organization. And this is where we often see symptoms of anxiety and depression. Here, the role function is just like what it sounds like. It's the relation or view of oneself in relation to others. And so this has to do with the known familial role versus the changing care role that they may be experiencing as a caregiver. And finally, the interdependence role has to do with our how we are connected to other individuals. And so this looks like social support as well as relational closeness and satisfaction in this space. And so, depending upon the level of adaptive coping that a person experiences and their in what domain, ideally, this leads to positive health behaviors. And so, another way of looking at this is that these adaptive coping strategies can be broken down into, or the coping processes can be broken down into different adaptive coping strategies. That are interpersonal, problem focused, accommodative, or meaning focused that help us to think about the level of coping. So, what I've done is did a survey with a cross-sectional survey of Black self-identified family caregivers or persons with dementia. As you can see here, the average age of the caregivers was 62. Most had some college and most were female. Most were taking care of their parents, which about 31% were spouses or significant others, and about a quarter of this group were taking care of other relatives and friends. Um, the adaptive coping strategies that were most commonly used amongst this group included the use of past experiences, planning skills, and humor. And so, between the focus groups and the information from this survey, we developed an intervention that was a virtual support group for family caregivers. And this included content that fell within all four of these domains. And so we included relaxation techniques, and sleep management, as well as blood pressure management, and taught folks. A lot of people don't recognize that the blood pressure is a basic test of heart function. And so we focused on some self-care activities. We also talked about what to expect around the disease process and how to develop more caregiving confidence, how to adjust relational expectations and to get what folks needed. And this took place over a 6 week period of time, which was based upon feedback from our focus groups who have examined the intervention. And so the outcomes that we expected to see as a result of this was decreased depressive symptoms, as well as decreased anxiety, stress, decreased caregiving burden, less social isolation, and better overall quality of life. What we found was that individuals who had more adaptive coping did see had an increased ability to manage disruptive behaviors as well as more control over upsetting thoughts. And in our pilot study, we also, this was the demographics of our pilot who participated in the virtual support group. As you can see, it was still similar to the folks that took our survey. And our intervention turned out really well. We had high program retention. We had 23 out of 25 that stayed in the program from beginning to end. We did see increased perceived social support, improved global mental health using the PROMIS scale, reduced depressive symptoms, anxiety symptoms, as well as psychological stress. We used the PSM-9 for stress. Others were PROMIS measures. And then there were also some other improvements, small improvements in self-efficacy for obtaining respite care and managing disruptive behaviors. So, of course, the next steps are to scale this intervention and create it in a way that it, or to update it in a way so that it can be delivered ideally by volunteers. Thank you.